what was the medication originally used for, and how did the idea to use it for encephalitis come about?
Right. So inebilizumab is a whole class of medications. There's many in the class called B-cell monoclonals, and so they deplete the B cells, the antibody-producing cells. Inebilizumab is approved for other indications. One of the conditions that we treat in neurology called neuromyelitis optica spectrum disease, it's approved for, and it was just recently actually approved over in the rheumatology space for something called IgG4-related disease. These are all rare diseases, right? And no one entity alone is going to be able to bring treatments to the rare diseases. It's going to have to continue to be collaborative. Business, government, funders, even benefactors. This is what needs to happen. Everybody has to partner in the rare disease space. That's the reality of it. We're not going to make progress if one person tries to go it alone in their silo.
Well, this has been great. Is there anything that we have not covered that you're like, I really want to make sure or are there any notes that you have verbally for our process just to make sure if there's anything that you said? You can also send me a message about this afterwards.
I think in NMDA receptor encephalitis, it is a rare condition. We have this unique opportunity to study it. I can say that again. NMDA receptor encephalitis is a rare disease, and we have right now a unique opportunity to study it. And if we don't take that opportunity, I'm not sure it's ever going to come along again. And so as a community of clinicians, neurologists, all the specialties, we have to sit down, confront our biases about what we think we're doing right, how we think we should treat things that's not evidence-based, it's not high-quality data, it's not what we call prospective, double-blinded, randomized. And we need to take the time to sit down with these patients and families when they present and say, this is where things are. Instead of just running in the room and saying, well, the last 3 patients, even though there's no approved treatments, I did this and they seem to get out okay. And so that's what we're going to do here. And in a busy clinical practice, you can see why that might happen. And so it's a big ask, I think, of the medical community to say, sit down, look at the trial, discuss it, get them access, give them the hotline. But if we don't do it now, we're not going to be able to get anyone to give us the chance 5-10 years from now and say, oh no, let's go it again, right? We have to work together, and we have to be dedicated to this now, because this is all a medicine. We wouldn't have any approved treatments if we didn't always say, what's my data? How can I make it better? Right? That's where we're at with this rare disease. And because it's rare, I think there's a tendency for people to say, oh, we can wing it. Maybe we don't need high quality data. And that's not true, right? We'll never make progress for these patients if we don't focus.
When you say that we have an opportunity we might not get it again, is that because you feel like, if we don't jump on this now, we'll have to start over with fighting for its priority and funding? Or what does that mean, that a window closes and then it might not open again?
It's all the things, right? Right now we have the interest of pharmaceutical development. We have the interest of some of the federal funders. We have a moment in time where we have good candidate drugs to test. That wasn't always the case either. And all of those things coming together, that doesn't happen every year. That doesn't happen, right? It's an opportunity that the people that came before me were working to develop. Here we are now. And the other piece of this that maybe we don't talk about enough is the longer we keep practicing without data,
home stretch. The thing we don't talk about often is
the thing that we don't talk about much is the longer we keep going on practicing with our biases as clinicians, the best thing I did last year is going to inform me doing the same thing this year, even if there aren't trials. The longer I do that, the harder it is to break that bias, to break that habit. I talked to a patient just last month, and they said, what do you mean the drug my doctor gave my daughter as it were, for NMDA receptor encephalitis isn't approved. That's impossible. And I said, well, actually, no, there's nothing approved. And she was shocked, right? Which to me means that, right, we're just, as clinicians, saying this is the treatment. And the longer we do that without data and without questioning and without striving to improve and learn more, it's dangerous, right? We're just going to get stuck in the habit of doing the same things over and over because that's what we did before. We've got to do better. I have to be able to walk in that room and say to that patient and their family, no, we studied this. And the people who had this condition before you, they were willing to study this because they wanted you to have an answer to the question I didn't have the answer to for them, right? But we've got to do it now, because if we don't get it together as a community and show, the funding agencies, show the patients, show everyone that we're committed to do this, we're going to do it right, even though it's hard, they're not going to stick around and say, okay, take your time and do it again in 5 years, right?
Yeah, it's great. Thank you so much.